Good afternoon, Chairman. Thank you for the kind introduction. So the discussion that we're going to have is about high risk or protected PCI or CHIP, which stands for complex high risk indicated percutaneous coronary intervention. Obviously, the time has changed since the first percutaneous coronary intervention by Dr. Andreas Grunsvik. I always enjoy looking at this picture and how the field has advanced since the first angioplasty. Full disclosure, this is one of my colleagues' case. This is a 75-year-old gentleman with acute coronary syndrome, non-ST elevation myocardial infarction, heart failure with reduced ejection fraction, and stage 4 chronic kidney disease. The first attempt or the first publication regarding high-risk PCI and how to risk stratify these patients was published in 2016. Basically, this same thing still stands with evolution of the risk factors that we incorporate in this high-risk indicated PCI patients. But overall, they relate to patients' clinical comorbidities, they relate to baseline hemodynamics, and the complexity of coronary anatomy. Why is it important to identify these risk factors? Because most of the patients who fall in this category are patients who need complete revascularization and quite often end up with incomplete revascularization. A lot of these patients are surgical turndowns because they are too high risk for surgery, or may end up having multiple procedures in order to achieve revascularization. And each of those in isolation, whether it's surgical ineligibility, whether it's incomplete revascularization, or multiple procedures, they come with a cost, and the cost is increased risk of adverse cardiac events. The first randomized clinical trial, which eventually led to approval of Impella, initially was 2.5, for high risk or protected PCI, was PROTECT 2 trial. This trial included patients who received prophylactic hemodynamic support, either with intra-aortic balloon pump or Impella. They usually had either left ventricular ejection fraction less than 35 or less than 30%, and protected left main or last remaining conduit. The primary endpoint was 30-day major adverse event, both at 30 days and 90 days. And for those who are, I'm sure most of you are familiar with this trial, the 30 days outcome was not clinically significant, but the 90 days outcome, which was a pre-specified endpoint, was significant in reducing the major adverse event. And of course, this was the trial which led, as I mentioned, to the approval of the Impella, initially 2.5 and then CP. As a part of the approval of this process, the FDA mandated doing a prospective registry, which became PROTECT 3 registry. One of the reasons the Impella or mechanical circulatory support in these patients work is by allowing complete revascularization. If you look at the subgroup analysis of patients who had one vessel treated compared to two or three vessel, you see significant reduction in those patients who had either 2 or 3 vessel disease. Similarly, these patients, a lot of them have chronic kidney disease, and one of the ways Impella or circulatory support seem to be protective is preventing associated acute kidney injury during this procedure by preventing arterial hypotension. This is the data from PROTECT 3 registry. If you look at any of the items, they all have significantly improved, and this partly shows obviously upgrading from Impella 2.5 to 3.5, and also familiarity with the technology, with vascular access and how to prevent bleeding, all of which can lead to major adverse event. Now, applying the same publication from 2016 to 2023, using the data from PROTECT 3, you see most of the patients who were in PROTECT 3, they all had multiple comorbidities, adverse hemodynamic, and complex coronary anatomy. So usually they all come in bunches, not that they have one comorbidity. They usually have complex coronary anatomy, adverse hemodynamic, and usually significant comorbidities such as ACS presentation. The utilization of Impella seems to be a risk modifier. If you look at the current available risk score that we can apply to patients with complex coronary anatomy, and then take the PROTECT 3 trial and use that data to see where they fall, the Impella or mechanical circulatory support in this particular situation, utilization of Impella CP significantly reduces the risk which was predicted by the NCDR or BCIS risk score. And this is why utilization of mechanical circulatory support in those patients with complex coronary anatomy, LV dysfunction, ACS presentation makes sense. Obviously, the live case that you saw being shown from Al-Qasimi Hospital was a complex coronary anatomy, but patient did not have significant LV dysfunction or adverse hemodynamic. Even though the anatomy was complex, the patient's clinical status and hemodynamic were not adverse. If any of those were present, then that would indicate need for utilization of mechanical circulatory support. The PROTECT 4 trial is a large randomized clinical trial looking at utilization of Impella CP compared to control, which may be no mechanical circulatory support or intra-aortic balloon pump. And it has subgroup analysis looking at renal function as well as viability studies.